Oh, here, I'll stand so they can see better.
Yeah, okay. Let's see. I'm trying to look at that. Okay, so this is, we're going to be going over the full head-to-toe assessment, okay, and everything that you need to cover in order to do a head-to-toe assessment. I will be doing a little bit of teaching through this, but I'm still going to go in order. Let's see. If you might hear us say VRN caps, VNR caps, which is an easy way for you to remember what order to do your head-to-toe assessment in. Okay, because remember, it's a head-to-toe. You're supposed to be working that way. And the reason why we give it an order, kind of, sort of, is so you don't miss anything. Because if you're going from the head to the feet, to the chest, to the legs, to the back, to the heart, to the abdomen, to the lungs, you're going to miss something, right? And so the V, yes. So V is vital signs.
Y'all take notes.
I'll write it up here so they know. V, N, R, C, A, P, S.
And y'all remember everything that we're going over in lab flows with what y'all have learned in class on Tuesday and Wednesday. So this is all still testable material, okay?
The Victor Newman thing, but who knows who Victor Newman is? Right, but do you know who Victor Newman is? Okay, so who knows who Vince Neil is? Here's Vince Neil, Motley Crue. No? In school, though, okay, so Victor Newman is an old-time soap opera guy. Like, he's in his 80s now. So I didn't figure anybody here would know him. Vince Neil is the lead singer for Motley Crue. Or, when I was in school, we made up our own, and it was very new RNs can act pretty smart. Okay, so whatever way you want to memorize it is fine. We're not checking you on your memory. We're trying to give you a tool so that when you get nervous, what do I do next? I can run through some sort of acronym in my head to guide you to the next step. Okay? So, Victor Newman, Vince Neil, very new RNs can act pretty smart. That's cool. Okay. So again, every check off is going to start off with safety. So again, you're going to wash your hands. You're going to notice there's more double starred items because as you go along, there's going to be more and more things that are going to be mandatory for you to do, critical elements. So washing your hand is always going to be a critical element. Introduce yourself and identify the client using two identifiers. That is now going to be a critical element for you. And then provide the patient privacy. That is going to be a critical element for you. You miss any of those things, it's an automatic failure. Now, it's at the beginning. Do you think if you forget to provide the patient privacy that we're going to tell you right now, and you start your physical assessment, oh, you fail? No, we're going to let you do the whole thing, and then we're going to tell you fail because you need to practice, right? So just know that to get those things down. Again, hand sanitizer will be at the bed. You will see us say, my name is Christina. I'm the student nurse. I'm going to be doing your physical assessment. Can I have your name and date of birth? She's going to tell me. I'm going to look at her armband. I'm going to say confirm that is correct. I'm also going to explain what I'm going to be doing, which is a physical assessment, and that I've already obtained vital signs, right? Because I did that last time I came in the room. Okay, so vital signs were obtained. And then I'm going to ask questions about how did you sleep last night?
Good.
Okay, how has your appetite been?
I've been eating less than normal.
Okay, and what brought you to the hospital today?
Been having some abdominal pain.
Okay, and we'll come back to that abdominal pain here in just a few minutes, okay? And so, level of consciousness. What do we check for a level of consciousness? Okay, what kind of question do I ask them? She already told me her name and date of birth. Do I already need to ask her again what her name is? No, I could say she answered the correct person. So person is correct. Do you know where you are today?
Lab,
Okay. Do you know about what time it is?
about 8:30, 9 o'clock.
Okay. And do you know why you're here?
Yes, because I'm having abdominal pain.
Okay. And so now I need to say she's what? Right. Awake, alert, and oriented times 4. You can also say AAO times 4. Either way is good. Okay. Now I have to do a full old CARTS assessment for pain. Her chief complaint was pain, and so now I'm going to follow up with that. So what do I ask for onset?
When did it start?
When did it, well, no, yes, so when did your pain begin?
About 2 days ago.
2 days ago, okay? And what do I ask for location? Can you point and show me where your pain is in your abdomen?
It's right here.
Okay, so now I know it's in her lower left quadrant. Okay, what do I ask for duration? How long no. We know when it started, right? So we know it's been 2 days. Does it come and go, or is it a constant pain? That's a duration.
Yeah, it comes and goes.
Okay, it comes and goes. Okay, what are characteristics? Okay, so can you please describe your pain for me?
It feels like a sharp, like somebody stabbing me with a knife.
Okay, is there aggravating factors? Is there anything that makes it worse?
When I get up and walk.
Getting up and walking. Okay, treatment. Have you been doing anything for the pain?
I took some Tylenol and Motrin.
Okay, and on a scale of 1 to 10, can you please rate your pain with 1 being less pain and 0 being the most pain?
It's about a 9.
About a 9. Okay, so she's in lots of pain, but she's got a smile on her face. Okay.
Oh, sorry.
Oh, I'm sorry. I did miss one. Radiating. Does it stay in one place or does it go to another place?
No, it's
I'm
just
sorry.
my abdomen.
Okay, so it stays in one place. Treatment, she's been taking ibuprofen, Tylenol. Severity, she rated it a 9 out of 10. Does anybody have any questions so far about the physical assessment? Yes.
What does that stand for?
It's vital signs, neuro, respiratory, cardiac, abdomen, periphery, and skin. Mhm.
And your patient during your assessment will have pain.
Yeah.
Can you say what this had to get involved with?
This? Aggravating factors, anything that makes it worse.
Can you repeat the AP and X?
Abdomen, periphery, and skin.
Thank you.
That is correct, right? Yeah. Skin and stuff, like their lines and their, all that stuff. Okay, any other questions so far? Okay, so now we're going to move, I'm going to scroll it down just a little bit. Find my pen light. Nope, okay, it's my pen light.
Do you want a pen light?
Okay, so now you can see I'm going to look at the mouth, the ears, and I'm going to assess for some cranial nerves, okay? So the first thing I'm going to do is I'm going to look at her lips to see what kind of condition that they are in, okay? And there's no cracking, they're smooth, they're normal color, that's good. Okay, so now I'm going to ask her to open her mouth and say ah. Okay, and I'm looking kind of in there. And what am I looking for? Her mucous membranes are pink, moist, and intact. Okay, what happens if her mucous membranes were dry? Right, she could potentially be dehydrated. What does it mean that the mucous membranes are intact? There's no lesions, there's no sores, there's nothing going on in there that shouldn't be going on in there, right? And then dentation. What did I say last week about dentation? Huh? Right, we're looking for the condition of the teeth, right? So we can say good dentation, meaning that they have all their teeth, they're in what we would say good repair. That means there's not like some half in there, cracked, broken, a lot of cavities, that kind of things. We can say poor dentation, meaning that they are cracked. There's a lot of cavities in there. They haven't had a lot of dental work done. But don't say no dentation unless the person has no teeth. Okay? Because that's what no dentation means, no teeth. Now, you will have patients that do have, the dentures in or whatever. And we would have to take those out to kind of look at the gums and things like that.
So before kissing, get the eyes and into the mouth.
Unless they have to.
Oh, yeah, I did. Guys, gotta keep me on track. Okay, let's back up. Whoop. Okay, sorry, I skipped. So we're looking at the eyes would be next. I'm so sorry. And we're gonna look at the cranial nerve, number 7. Okay, and I'm gonna ask for cranial nerve number 7, how many fingers am I holding up?
2.
You can hold up how many of her fingers you want on one hand. She said 2, correct. Okay, now I'm gonna look at her pupils. So I'm looking directly at her. Her pupils are equal in size and they are both round. So that's equal and round. Now I'm gonna use my pen light and I'm gonna ask her to look into the light so I can see if her pupils, what should her pupils do when they look in the light? They should constrict, okay? And then when I take the light away, they should dilate, right? Okay, so how do I do that? I'm gonna come in real quick and out real quick. Both pupils then did constrict, and so I could now say reactive to light. And then accommodation, I've been told this is the way we're doing it now. Look at the pen, look at the wall. Look at the pen, look at the wall. Okay, when she looks up close, okay, her pupils should constrict, and when she looks over at the wall, her pupils should get bigger. That is accommodation. So now I can say I have checked cranial nerve 3, 4, and 7. She has Perla, okay? And now I'm going to do the 6 cardinal fields of gaze. So I'm going to tell her, move, follow the tip of my pen, and only with your eyes. And so there's 1, 2, 3, 4, 5, 6. What am I checking for when I ask her to do that? What is that called?
Oh, that's the nystagmus.
Nystagmus, right. We're wanting to make sure she has good control over her eye muscles. And so, yes, we're looking for nystagmus. Okay? Then we're going to come back down to mouth, ears, nose, or mouth and ears. And again, we're going to look at the color of her lips, normal, no cracks, no lesions, sores, anything like that. I'm looking at her mucous membranes. I had her say ah. Her mucous membranes were pink, moist. She didn't have any lesions, and she has good dentation. Now I'm going to check cranial nerve number 5. Notice I'm saying all this. This is what we want to hear from you. Okay? So I'm going to check cranial nerve number 5. Could you please clench your teeth? Okay? And so what I'm going to do is, sorry, don't clench them. Sorry. Clench your teeth. Okay? I feel both muscles engage equally in her jaw. Cranial nerve number 7, can you please smile? Puff out your cheeks and raise your eyebrows. Okay, thank you. So cranial nerve 7 is intact. I'm going to check cranial nerve number 8, and I am going to check, do you have any difficulty hearing? Okay, and we still do the whisper test, right? Okay, and so now I'm going to check that. Even though she says she doesn't have, you're going to have a lot of people say they don't have any problems, right? But we're going to check behind them. And I'm going to do what we call the whisper test. And I'm going to go over here and I'm going to whisper.
1, 2, 3.
And I'm going to come over here.
X, Y, Z.
Okay, so now I can say cranial nerve number 8 is intact. Cranial nerve number 9 is the uvula moves up and the soft palate rises. So what does that look like? Okay, so I need you to open your mouth and say ah. And I have to use my pen light to see all the way back there. And when she says ah, get with your partner, make sure you know what that looks like. But the back of your throat, the soft part, not the roof here, but the back part, it should rise. And you'll also be able to see the little hanging ball rise, the uvula rise. And gag reflex is intact. Now, we are not checking each other's gag reflexes, okay? That is cruel and unusual punishment. But we're going to assume, since she's AAO times 4, and for the purposes of your learning, we are not going to do that. But there are times when we would have to check a patient's gag reflex. If we had to check a gag reflex, how would we do that?
With the tongue compressor.
What? I'm just not going to...
Yeah. So last semester we did have y'all just say, do you have any difficulty swallowing? That way we know you're still putting that
in there.
all that together. So just ask your patient, do you have any difficulty swallowing? No. Okay, gag reflex, good.
Okay. And so the next cranial nerve number 10 is, do they have any difficulty swallowing? So that's the next step. Okay, cranial nerve number 11. Here we're going to place a little bit of resistance on their shoulders, and we are going to ask them to turn their head from side to side. Okay, and shrug your shoulders. Okay, and so what am I looking for when I do that?
Equal strength.
Okay, I'm looking for equal strength, that she's able to have full range of motion of the neck, and that when she shrugs, she has equal strength on both sides. If those two things, she's able to do both of those, then we can say cranial nerve number 11 is intact. Now I'm going to test cranial nerve number 12, and here I'm going to ask her to stick out her tongue, move it side to side, and what am I looking for? I want to make sure when she sticks it out that it stays midline and she's not like that ugliest dog in the world whose tongue always goes to the side automatically, but that it comes out in the middle and that she's able to move it equally from side to side and that there's no deviation. Any questions on eyes or the mouth, cranial nerves?
So what would you say, would you say, for the tongue, would you say there's no lateral deviation?
Right, that's correct. You would say that there, where is it? The tongue has no lateral deviation. That's fine. Okay, no other
You're
questions?
verbalizing all that to us.
And able to move side by
Side,
side upon request.
Okay, so stand up so they can do lungs. Okay, so you have to know that we assess lungs by inspection and auscultation. Okay, what are we inspecting when we look
Chest.
at the chest for?
Is it chest or is she breathing?
Correct. We're looking at the structure, making sure that there's symmetry and structure. Okay, and then in the back, what are we looking for as well? Symmetry and structure. Because if a patient has scoliosis, their structure is going to be off. Okay, because of the scoliosis or hunchback and all of that. So we want to make sure that we're checking for structure. We're also going to make sure that when she's breathing, we don't have to necessarily count. We've already done that, right? We did that in vital signs. But we're making sure that the chest rises and falls symmetrically. So that when she raises, one side of her chest doesn't come out and the other one stay down. We have a major problem if that happens, okay? So we want both sides to rise and fall. And when we look at her back, kind of the same thing, that there's nothing moving that shouldn't be moving and that both sides rise and fall. Okay, we're looking at that whether she's labored or unlabored in breathing. And right now she's not exercising. She's sitting here allowing me to torture her. And so her breaths are even and unlabored again. Okay, so now we're going to do the anterior. This is the anterior and this is the posterior side, right? Okay. So for anterior side, listening to the lungs, where are our points? Okay? It's okay. We'll just use you. There's a picture in your book. We do not say you have to listen to 10 points or 15 points or 20 points or whatever. What we're looking for is that you cover the whole chest field. You do upper, middle, and lower, okay? And that you do it in a comparison pattern. So whatever is going on one side, you need to listen to on the other side and you're comparing side to side. You don't want to go all the way down the left and then all the way down the right. That doesn't give you good information. Good information is what's going on the right is the left or the right. And lateral, but we're just doing right now the anterior. So, can I listen to good breath sounds over breast tissue? No, not really. So, for women, you have to displace breasts. Men, this is going to be odd for you, but guess what? We don't make you do that. But no, you may have to do that in practice, okay? If you make it normal and act normal and professional, most of the time your patients don't have a problem with it, okay? But if your patient is able to displace the placement of their breasts, just ask them to do it on their own, and they will lift and divide and all that kind of good stuff. Where else do we not want to listen? Not over breast tissue and not over what? Huh? Yeah, that's good, a pacemaker.
The ribs.
The ribs. Can we hear the lungs over a bone? We cannot. Okay, so we're going to find like where the ribs are. We're going to find a good intercostal space. We're going to work from side to side. And I'm going to listen. How long do I listen? 1 full inhalation and 1 full exhalation, 1 breathing cycle. Okay, and then I'm going to go straight across and I'm going to listen here. Okay, I've just done the top of her lungs. Okay, I'm going to come down a couple of spaces. I'm not over breast tissue yet. Okay, I'm in an intercostal space. 1 inhalation, 1 exhalation, I can move on. I'm going to go directly over to the other side. 1 inhalation, 1 exhalation. Okay, I've done kind of like the upper portion. Now I'm going to go to the middle. Can you please move your breast to the side? Okay, and I would kind of get in here. It's kind of hard to do over clothes, but I would still find that intercostal space and listen. Intercostal space and listen. And then I'm going to listen across the bottom. Again, 1 full inhalation, 1 full exhalation before I move. Okay. Now I've done top, middle, and lower. That's good. Okay. On a bigger person, 6'7" guy that's a basketball player, you might have 10 spots. Okay. But on an average size female, it may only be 6 to 8 spots. Okay. But make sure you do 2 at the bases on each side. Okay. Because your heart starts at lungs start at the apex. It's skinnier and then it gets wider at the bases. So you need at least 2 at the bottom. Okay. Let's go to the back. When we get to the back, what do we want? Where do we not want to listen? Over bone, right? The scapula. So what are we going to ask our patients to do to open up that scapula so that we can hear the lung fills? We're going to have them tuck their chin to their chest and to give themselves a big bear hug. That opens and it's going to make what we call the Christmas tree pattern there. And again, I'm going to find an intercostal space there, best I can. And I'm going to listen, 1 full inhalation, 1 full exhalation, and I'm going to move right across. Okay, I'm going to go mid. Try to do that again. Again, I'm feeling for right there is her scapula. I'm going to go on the edge of the scapula, not over it. And move right across the spine to right there where the scapula is not. And then I'm going to do at least 4 across the bases. Again, scapula is ending here. 1 full inhalation, exhalation. Okay, so now we're going to move to the lateral version. Okay, so how many points do you listen to on the left?
2.
3 on the left, right? And 2 on the right.
Ms. Akins, which lung has 3? Which one has 2?
This one has 3, this one has 2, because this side has the liver.
I was the right side? No, the
No, this
left
is,
side
where's your
has
heart?
2 because
Your
there's
heart's
a
Your heart, yeah.
And then your right side has 3 because there's
Yeah, your heart's over here, so you have 2 on this side.
Okay, 2, 3.
There we go.
Okay,
All
sorry.
right. Takes us a minute.
It takes us a second. Now turn sideways.
But hey, I'm just looking at my calendar. Did she mention where the lungs are predominantly, anterior, posterior?
Posterior.
So you're gonna hear better posteriorly usually,
Oh, I hope I'm not sweating.
especially in the bases.
So 3, we said 3 on the right, okay? So we're going to find that mid-axial line. Inhale, exhale, inhale, exhale, and inhale, exhale. And then 2 on the other side. Okay, and then what should I say? It's not on here, but what should I say? Because anytime I do an assessment, I have to report what I've just assessed. Clear to auscultation. Okay, clear to unless you hear something in there, then they're not clear. But we're assuming she's healthy.
Is this correction though? This is what we're giving our videos. Yes, but you just don't have to
Miss
do
Tabor,
Yes.
I have a question. You know how you, with business, too, how you did like
Y'all
this,
listen up.
this, and then you do like
Uh-huh.
this? But can we do this, and then go down?
Yes. Yes. As long as you're going side to side, it don't matter if you go right, left, right, left, right, left, or if you go right, left, left, right, right, left. That part doesn't matter. I just don't want you going all the way down and then all the way down.
You always want to
So on the
compare.
front, there's 6 points.
It don't matter, as long as you listen to upper, middle, and lower. I don't care how many, we don't care how many points. We just want to make sure you're covering the entire lung field. Because the points may change. Again, somebody that's teeny tiny versus a 6'7" basketball player whose chest is huge, the lung field space is going to be different. Okay? So as long as you get top, middle, and lower, and you're listening and covering all the lung field space, I would say there's no 10 spots or 20 spots or whatever.
And that's front and back.
Our own stethoscope.
This is with your own stethoscope. We're not listening with you, no.
Sure.
It's like on the video, there's like 18 points.
Yes.
Yeah, her picture had 20 points. Yeah.
Okay, so any other questions about lungs before we move on to cardiac? Yes.
Normally you would do this under the clothes,
Yes.
but here we're just doing it over
Yes.
the top.
And usually in the hospital also, women are not wearing undergarments, so you don't,
You
it's,
just ask them to drop back out.
Yeah.
yeah, just move it to the side.
Move it to the side. You can go underneath. Okay, shh, we got questions. Everybody needs to listen to the questions. That way the same questions aren't being asked.
So just to double check, I know it's like, you talked previously about how it's easier to do all the posterior on once, correct? Or is it okay to jump back and forth, like for example, whenever you're listening to the lung?
Okay, so it depends on your patient. Okay, what patients are going to wear out easy? Okay, if you already know somebody has a breathing problem, right? Okay, so yes, if this is an emergent situation or it is an older adult that's going to wear out, we want to hit the most important spots first, which are going to be the posterior at the bottom. Because generally, if they have an issue or they're developing pneumonia, gravity works and gravity is going to pull all that fluid down. Okay, so that's where your problems are going to lie. Okay, that's a real life scenario. This is textbook.
Gotcha, I just didn't know for like the actual assessment, is it okay if they move back and forth and like?
Well,
like,
I
to
would
basically,
do the back. I mean, the only time I would do like change anything up is if it's one of those patients, and then I would go back and then do front and sides or something like that. But I wouldn't go, I'm going to listen to the basses here and then listen to the basses here and then come back over here and listen to the up.
That's
And
gonna
then
wear them out.
that's going to wear them
I
out
will
too much.
say, so as you're seeing this and stuff, so, and we'll show it, it's easier when we're in a bed. Okay, when you have them, when you're about to assess everything, okay? Best rule of thumb is just like have them sit up, do their bear hug, listen to their posterior, then they lay back, you listen to their anterior, and then immediately after listening to their respiratory anterior, then you start listening to their cardiac, and then you go into abdomen. That way you're not listening here, have them move, laying back, you know. So once they sit up in bed, just go ahead and listen to that posterior, and then when they lay back down, now you just do all your anterior.
Oh, okay, gotcha.
Yeah.
I just didn't know like what's the smoothest way without
Yeah.
rolling back and
Right.
forth, you know?
Okay.
Do it that way in the checkoff or do we?
It doesn't matter how you do it in checkoff as long as you do it and you don't forget one aside. Okay, we're going to move on to the heart. So for the heart, again, we're going to inspect the heart.
I'm gonna have a picture up, because I know they, sorry, I'm a visual.
What size your stethoscope? Like the little box on your.
You're still going to listen to
I'm
the,
talking about on your stethoscope. You have a box on. What is?
oh, because it's a digital one
Oh.
for hearing impaired, and it just came from the lab. I forgot, I didn't bring mine.
I'm a visual, so I like this too, so. For your cardiac. Because you do have to, as you're doing cardiac during your physical assessment, you have to say every single thing on that.
Okay, so we still start off with inspection. What are we inspecting for when we're doing a cardiac assessment?
Are we doing the carotid, like the distended?
No, we're just talking this right here, the heart. Okay, we're looking for pulsations, we're looking for bruises around the skin, what else? Heaves, did I hear that? Heaves, did she talk about heaves in the lecture? Where you can actually see the chest wall kind of rise when the heart's beating hard?
Like see the pulse.
Okay, you can see it? Okay. Okay, a thrill is yes, you can feel the thrill, but that comes with palpation. So we inspect, and then we can palpate, right? Or actually would auscultate. So when we auscultate, we'll do this first. Those points you absolutely have to do all 5 of, okay? Again, it's a visual. How do we find our second intercostal space?
Y'all feel that indention right
I
here?
don't have. No, it's down here. You
That
can
little bone.
feel. Like, okay, so there's your little indention here. If you come down a little bit,
I feel that bone.
it flattens out, and there's a bone, and there's a dip in that bone. Okay? And then, once you pass that, you should be in the second intercostal space at that dip. Okay?
That little rise and
Huh?
Right here?
the rise.
Yeah.
It's like a flat.
Right, and the rise, right. So if you go to the side of that, you should be in the second intercostal space.
Side of the rise.
Right. On either side. We'll practice finding it in a little bit.
And then you feel your ribs, and then you have like a space, a space.
Huh? Right. So, I mean, it's kind of the same thing because it's either way, yeah, it's
We
fine.
just want you to be able to find it. That's where you're
Right.
at.
Okay, so here we go. I'm going to find her second intercostal space. Okay. I'm going to place my stethoscope. And I have to say, second intercostal space, right sternal border. Okay? And how long am I going to listen?
1 minute.
No, at least one lub dub. I need to hear the lub and the dub. Okay? Then I'm going to move directly across the sternum. Okay? Because again, I have to stay in that intercostal space, not on the sternum. And I am then at what? The pulmonic. What am I, when I say aortic and pulmonic, what is that?
What structure?
What structure of the heart? Good question. Good. You're listening to the valves, opening and closing. Okay, so the lub dub, the lub is, you'll hear it better down here, and the dub you hear better up at the top, and I'll explain that in a minute. Okay, so I'm listening to the pulmonic valve at the second intercostal space. Then I'm going to go down an intercostal space, and I'm going to listen, and here I'm at Erb's point. And this would be the third intercostal space, left sternal border. I'm going to go down another one, and again, I might have to ask her to displace her breast. Then I will be at the fourth intercostal space, left sternal border is tricuspid. And then the mitral valve is going to be the fifth intercostal space, mid-clavicular line. So your clavicular line is going to be your collarbone, your clavicle, halfway down between the sternum and the shoulder, find the midway point and come down. And this is your mitral valve. This is also the apical pulse, which might be a test question, right? When do we listen to the apical pulse other than this? Huh?
When you can't find it, you go radio.
Okay. So when I'm done with this, I say S1 and S2 are heard distinctly. Okay? When you take a radial pulse, like if you're taking vital signs and you notice your patient's heart rate is irregular, you will have to take an apical pulse for 1 full minute. Okay? And that's when you're taking vital signs. There's also times when you will take an apical pulse when you administer a drug. Okay? We haven't learned drugs yet, but if you want to be, digoxin, you have to take an apical pulse for 1 full minute before giving digoxin. Okay?
This is under your lab day 2. Make sure you know, and that, look, you even have a cute little All People Enjoy Time magazine. So make sure you know all those landmarks and where they're located, okay? During your checkoff, you will have to, each landmark, it's on your checkoff, you have to name every landmark as you're listening, okay? And then also, you might see test questions on,
Where
where's
is
your
this
apical
found?
pulse. You need to know your apical pulse is in the 5th intercostal space, mid-clavicular. There we
Okay.
go.
So when we say S1, that is the lub. Okay? Which is the closing of the mitral and the tricuspid valve. So when you are listening, the lub up here, the lub dub, the lub is going to be fainter than the dub. Okay? When you're down here, your lub is going to be louder than the dub. Okay? And your S2 is the closing of the aortic valve and the pulmonic valve. When you get to Erb's point, it's kind of equal. Okay? So again, S1 lub is going to be loud down here. S2 will be loud up here, and they will be kind of equal about Erb's point. Okay? Any questions on cardiac? So after you listen and you name your all your different points, you'll state S1 and S2 are heard distinctly, and heart is in regular rhythm. Okay? Any other questions before we move on to the next thing? Okay, abdomen. You have to pretend she's laying down. This is her bed. When I inspect her abdomen, we're playing. She's not going to lift up her shirt, and neither is your partner. Okay? We have to pretend really well. What am I inspecting for when I look at her abdomen? Okay? Okay, I'm looking at skin color, skin texture. Is it normal for her ethnicity? Is there any discoloration? Is there bruising, bulges, any kind of funky looking moles, anything like that on her abdomen? Scars for surgery, yes, thank you.
And what's this called? Stretch marks? Where is it?
You're a
Striae, very good. Okay. So basically you would say, I'm looking at her abdomen. I don't see any surgical scars. Skin is normal for ethnicity. There's no lesions, masses, bulges, anything like that. So you would just say what you're looking at. Hernia assessment. So I'm going to have to assess her hernia for a hernia. What am I looking for? A bulge where?
Or an umbilicus.
I never knew what an umbilicus was in school. I felt so stupid because I had never heard of it's your umbilicus, right? But I'm a Yankee. But you will hear some people say umbilicus. And I was like, I've never heard of that before in my life. I need to go figure out what an umbilicus is.
Tomato.
Yes. So you're going to have your patient lay down flat in the bed. You're going to have them draw up their legs.
Both legs.
Like this, both legs.
I
And
just
you're going to
picked it.
ask them to do a what?
A crunch.
A crunch. Okay? If they have an umbilical or hernia or umbilical hernia, you will see like a golf ball pop out there. Okay? Some people don't even have to do the crunch, and there's a golf ball there. So you will see all kinds of things at the Walmart. Start assessing the people walking up and down the aisle. No. Just saying. Just saying.
Yes.
Then I'm going, what?
I'm so sorry. Just a question. The hernia, you can see it in that way. How do you differentiate between a hernia and like a AAA? An aneurysm. Can you see that from the surface like that?
No.
Really?
You might can feel the thrill of it. Okay, thrill. Somebody said that. If I hear, let me go back cardiac real quick. What's a bruit? Or what's a murmur?
An arrhythmia.
It's not an arrhythmia. It's a regular blood flow. Okay, so that means when the valves are opening and closing, it's not going through that door smoothly for whatever reason. Okay? Normally, in a heartbeat, the ones you've been listening to, you're going to hear lub dub, right? And a murmur, it's going to go whoosh, 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 and it'll sound really funny. Okay, and so that would be a murmur. When we feel a thrill, that's how you remember what a thrill is, right? Is when I palpate the heart and I come down to where her mitral valve is, which is the fifth intercostal space mid-clavicular line. If I feel like a cat purring, that is kind of a thrill.
I think our paperwork says that a bruit is the swish sound.
Okay, but a murmur is the swish sound in the heart. A bruit is a swish sound anywhere else in the body. So where would you hear a bruit? In the carotid? If a patient has a dialysis port, you're going to hear it where the graft is. Okay? Because it's an artificial graft versus their normal structure, and it causes turbulent blood flow. If you're listening to femoral pulses, you may hear a bruit. Okay? If you're listening to the aorta down here, you may hear a bruiting. But a murmur is only related to the blood flow in the heart itself. Any other turbulent blood flow throughout the body is a bruit. Okay?
I don't hear murmurs often, so when I hear or read in a note that a patient has a murmur, I'm like, ooh, can I go listen? Because I don't hear it often.
And that's what y'all need to do in clinical. When you get there, you're gonna find all these weirdness things. And if the patient's good with it, we're gonna see if other
Yeah.
people can't come listen. We had one
Let's
lady
go see
bring
this.
forward, she was like, you wanna get everybody in here? I mean, she's.
Yeah.
That's how I learned breath sounds, just constantly listening to everybody's breath sounds, because it's different from a video recording versus actually hearing it on a patient. So take that opportunity, go listen.
Okay, so back to, we've inspected the abdomen. We've had the patient do a crunch for a hernia. Now I'm going to auscultate. Where do I start auscultating? The what? Right lower quadrant. How long do I wait? Gurgle, gurgle. We can move on. We know there's bowel sounds. Gurgle, gurgle. We can move. We go up to the upper right quadrant. How long do I wait? And then I go over like a clock to the left upper quadrant. Gurgle, gurgle. Down to the lower left. Gurgle, gurgle. I can move on. How long do I have to wait if I do not hear bowel sounds in any given quadrant? 2 minutes. I think I said wrong because it flips, and that's what you guys have to be prepared for. A lot of our standard evidence-based practices change because of research. When I was in school, and a lot of times that's what I fall back to, it was 5 full minutes in each quadrant. Now it's only 2. Okay, but let's say I don't hear in the upper right quadrant any bowel sounds, and I listen for 2 seconds. What do I do then? I keep going, right? Until I complete the whole cycle.
Minutes.
Minutes. I go to the upper left quadrant and I don't hear anything. I listen for 2 minutes. Lower left, I listen for 2 minutes. What do I do next?
You don't hear anything?
And I haven't heard anything. Get them up, get them moving. If they're not able to move, I can get them rolling in the bed at this point, get them moved to side, sit their bed up, lay it back down. So, depending on your patient, what's going on. If they can't do it themselves, you need to move them however you can without hurting them. Okay? If they're ambulatory, get them up, walk them to the nurse's station, walk them to the end of the hall and back. Then we're going to repeat the cycle. Okay? And let's say this time there's still no bowel sounds. What do I do then? I'm on that phone to that doc, okay? But if bowel sounds come back, we're good to go. But my red flag is already raised, right? Thinking, okay, I had an abnormal. I'm going to keep a close eye on that, okay? And I'm just not going to let it go. But if there's bowel sounds, I can go on about my business. Just keep a close eye on it. But if there is nothing, the second go around, I'm on the phone with the doc.
Do you still document that there were no bowel sounds?
Absolutely.
initially, And then you go and walk?
Yes.
through?
You document everything you do.
If you hear no bowel sounds and you're about to walk out to go call the doctor and the patient says, hey, can you bring me a sandwich because I'm hungry? Are you gonna bring them any food?
Right. Also, I would not document that there was no bowel sounds until after I got him up and walking. Okay? Because if somebody got in the chart and the doctor's like, oh my gosh, there's no bowel sounds, but you're walking the patient, okay? So you would say, okay, in your head, there was no bowel sounds, get up and walk the patient. Then I would come back and document there was no bowel sounds, ambulated the patient, to the nurse's station, reassessed bowel sounds. Bowel sounds normal.
Why do we auscultate in that pattern versus the comparative?
Because that's the way your tract flows.
And so it kind of
Your GI
empties on the left side.
Your guts aren't symmetrical.
Yeah. Always think of it empties on the left.
Yeah. Comes up on
That's why I think in my head when my stomach's aching or something, I lay to my left side because I'm trying to like get all that kind of going to my left.
Okay. Then we're going to palpate. How do we palpate as nurses? We do light palpation. Okay, so make sure you know the depth of that. Normally it's around a half an inch to an inch. We don't do deep palpation. We typically don't go because that's what your nurse practitioners do, your PAs and your doctors do, okay? What am I going to use? Oh, percussion. I'm sorry, percussion. Okay, so we can percuss. How do we percuss? Take our hand, put it down over the right, and you can hear, when you hit those bones, you can hear a sound. What should that sound kind of sound like? Hollow. Right, because you're over gas, basically, and maybe some stool, right? But it should basically feel hollow. Okay, what happens if it thuds? It sounds solid. Okay, you could be over stool. There could be a mass. Okay, then I come over and I'm still following that same order, and I'm listening to the sound that I make. Cortland, you had a question? You do it in this order: percussion, then palpate. Do it in this order. That's how you get your points. Okay. And so you document. How do they document that when they write it? It's
Timpani. What word is it?
Timpani heard, no dullness. Dullness indicates stool or a mass. Okay, now I'm going to palpate. Again, around a half an inch to an inch in. What do I use to palpate? Kind of fingertips or the length of your fingers. You don't want to go in like this because if you do this, you're not really touching anything, right? I mean, you're just touching those 4 places. So kind of get in there, use like the whole flat surface of your hand, and you're going to push in and you're going to feel. What should it feel like?
Soft.
Straight.
It should be soft. It should be soft. Should not be in any pain when you touch. So a lot of times when you're doing this, what should you be doing? Watching her face to see if there is pain. What kind of pain did she complain of earlier? Abdominal pain. So might I be a little bit more gentle with her abdominal pain? Yes. So, but I'm definitely watching her face as I do that. You get points, hold on, for correct order, and then I'm going to ask her, do you have any trouble with urination or having a bowel movement? And when was your last bowel movement?
Yesterday.
Okay. What was the question?
Would things be harder to feel on a pregnant female?
Yes.
How would you do that?
You're typically not.
They're gonna, unless you work
Unless you work L&D.
Okay.
But like if you work in an ER and she comes in and she's got the pregnant belly going on, you're not going to palpate that.
Or even like a man who has.
No, you would still feel that because that's totally different. But we're not going to do anything on a pregnant lady that could potentially harm, right? I'm not trained to do that. So, who else had a question?
So you saw a hernia.
We're kind of confused because last Thursday you said palpate
I know I probably did it out of order because I didn't have the rubric, but this is correct, right here. This is the correct order. Sorry that I misspoke. This is the correct order. Yes.
I need for question. You said timpani heard what?
No dullness noted.
Good question.
Timpani heard in all 4 quadrants, no dullness noted.
What was the question? I'm sorry.
That's what you say.
What would you say or what would you document? Okay? And we're going to show you here in a little bit what, if you wrote out a full physical assessment, what it would look like written. So we'll get to that part. Any other questions before we move on? Yes, sir.
So what happens if you, up there, you notice a hernia?
Uh-huh.
Are you doing any?
You will not do anything. Do not try to put it back in. Don't do anything. You're just going to document umbilical hernia noted
And
or present.
When it comes to this portion, you're not going to do any of the palpation or any of that stuff? Or are you gonna,
When it comes to what?
so as you move through, let's say you saw a hernia.
Right.
Are you still going to keep doing everything?
Yes, I'm still going to do everything. Still going to do everything. But I'm not going to, again, I'm going to work in those quadrants. And then you notice the umbilicus is in the middle of those quadrants. And I'm not going to push on the hernia itself.
And you don't let the patient know?
Huh?
You don't say anything to the patient about it?
Patient probably knows they have.
They have a hernia. Yeah.
Yeah,
Oh,
but,
that's how long have you had it and haven't got any trouble
Right.
with it?
right.
What if I have a hernia that's not an umbilical hernia?
Well, where have you been assessing to find out if there's a hernia?
What if it's like an inguinal hernia?
That's what I was
Well, we're not assessing those.
It's gotten there yet.
Can they migrate into a little?
Huh?
I've seen that.
I'm not an expert in inguinal hernias.
Yeah. We don't even learn to teach other in the first level.
Yeah,
So we're just making fun.
yes.
We're
Okay,
teaching you first level stuff.
I do make a note, when it comes to hernias, it's small, moderate, large. I mean, some of them are, and like she said, they know. They've
Yeah.
had it for a while, they know.
My
okay.
husband has a hernia. He don't. Just from straining, from working out and everything.
Okay, so now we're to the skin and periphery. Periphery and skin. We're going to do bilateral upper edema. So this is where I take both arms and just kind of light squeeze down. You're going to be able to tell the difference. I know it's weird, but your fingers may leave impressions. You're going to feel the edema. It's not going to feel the same. But definitely when you squeeze the hands, you're going to be able to tell what edema looks like. With some people that wear rings, you can see their rings embedded deep and you can see the skin up and around. Okay. Then we're going to do bilateral temperature. It don't matter these what order. Temperature is always gauged with the back of the hands. And we're just going to go down both hands. At the same time, we are comparing side to side. Okay, that's important. We always compare side to side. What is skin turgor?
When you pinch.
When we pinch, okay? So I'm going to pinch up here. Checking, what do I say when it goes back?
Normal or instant skin recoil.
Instant skin recoil. What do I say if it stays up? Tinting, present, or you can say delayed skin recoil. Either way. Now, what is the issue with doing this sometimes?
If it tends to me,
If it's with an
Yeah.
older patient?
With an older patient, their skin may tint automatically, but they may not be dehydrated. Okay? So feel the clavicle is the best place to do that, although they say you can do it with the back of the skin. But I'm hesitant with that, again, because people's skin is just different.
Do we have to rate the edema +1, +2?
No. Capillary refill in fingers. So again, I'm pushing each fingernail, looking for it to blanch or turn white.
hopefully not.
Yeah, hopefully not blue. Okay, what do I say if they are normal?
Normal capillary.
No, I don't say normal. We try not to use the word
Less
normal.
than 2 or less than 3.
Capillary refill in all fingers less than 3 seconds. Okay? I know it's a lot, but if you practice over and over and over again. Okay, the next is the radial pulse, like we did before. We're just going to feel here. It's +2. We're not going to do the rate. We've already done the rate, but she's in regular rhythm. Okay, then I'm going to move to the lower extremities. I'm going to do the same thing, back of my hands, down both of her legs at the same time. Okay, I would say temperature and bilateral lower extremities. is warm and equal.
I do have a question. Before you even move down to like the lower legs, wouldn't you go ahead and go to like the grip strength, like before you even go
That's
down?
up to you.
Yeah, it's up to you.
But we try to keep it separate so that when you get stuck, remember, you can do this. If you start mixing up things because it's easy for you, if you get stuck, you're not going to be able to unstick yourself most of the time, okay? If you feel comfortable because maybe you're a tech, maybe, I don't know, you feel comfortable, you've been practicing super good, you've got it down. If you want to do certain things together, that's fine, but I guarantee you, you're going to be nervous, okay? And so just
You can get
stay.
off track that way.
Yeah, you can get on track, and it's hard to get yourself back on because now you don't know where you are in your process.
But if you confidently know, okay,
Right.
here's all my upper, do the strength, all that stuff, now I'm moving to the bottom, we're gonna do that, then you can do that. Like, there's not points or
Do
anything
y'all-
like that.
For the big head to toe, do y'all allow them to use cards,
Nope.
And practicing though, what might help is to put each of these things on a card, like an index card. And that way you can have that index card next to you as you're practicing. And it is practicing to say all this stuff over and over to where it just rolls off your tongue. And thankfully, most of your lab partners are gonna be normal folks.
Okay, so we're back to bilateral temperature, back of hands all the way down. Bilateral lower extremities, warm and equal. Next thing is edema. Now here, checking edema in the lower extremities is going to look a little different. What do? Thumb over the shin, right? And if she has edema, what's it going to look like? There's going to be a dent. We are not grading it, so you don't have to do that and check off, but there may be a test question about it. Okay, I can't guarantee that, but I have seen that in the past where a person has 3+ pitting edema, how deep, or when they press, they have this deep of an indentation. How would you grade that? +1, +2, +3. So I believe there is a chart in your book that says +1 is this big of a dent and it stays this long. So make sure you look at that. +2 is this deep of a dent, this long. Okay, I would check your capillary refills on your toes. Yes, you are going to have to take off your partner's socks. Yes, you are going to have to check capillary refills on their toes. Okay, and then you would check each toe. Again, capillary refill in bilateral feet, lower extremities are less than 3 seconds. Then we're going to do the dorsalis pedis pulse, which is on the flat top part of your foot. Okay? And then we would do both of them. And we are not going to check the rate. Okay? We're only going to check the quality, +1, +2, +3, and even make sure they have one. Okay? Because it's dangerous not to have a pulse in your foot. Okay, then we're going to look for moisture all over. So does she look pretty dry as far as skin, or does she look like she's sweating or diaphoretic, you might hear? So I would say she's pretty dry. She's not sweating. And then color. Her color is normal for ethnicity. She doesn't really have like vitiligo or anything like that. And then I'm going to roll her over. This is a critical behavior, so make sure you roll your patient over. What are we looking for on the back side? We're going to look at the condition of the skin. But the important parts of the skin to look at on the back side are the pressure points, because that is where skin breakdown is going to occur. So we're going to look at the back of the skull. We're going to look at the scapula. We're going to look here across the sacrum. And we're going to look at the heel bones, okay? And we will say that the skin is intact, no breakdown. Neuromuscular, again, we're going to check grip strength. So I'm going to say, please squeeze my fingers. Okay, what am I checking for? Equal strength. Why do I only give her 2 fingers? It does not hurt. She can squeeze all day, every day. Even a man that's 6'7", buff, he's never going to hurt your 2 fingers, right? And that's true, they won't. Don't give them more than 2 though. But yes, you're looking for the grip strength equality in both hands. So you would say grip strength is equal and bilateral upper extremities. Then you're going to go to the foot of the bed and you're going to track her dorsal flexion. So what does it mean to be dorsal flexed? Up like a shark. That dorsal fin is up. So I'm going to say, please point your toes to the ceiling. And then I'm going to say, push on my hands. And then she's going to push like she's pushing a gas pedal. Plantar flexion. Whoops, I did that backwards. Dorsal flexion, I'm going to have her point to the ceiling, and I'm going to put my fingers on the tops of her toes and have her pull up her dorsal fin. Sorry. Plantar flexion is she's going to push down like a gas pedal. Okay? Any questions? We're going to end with safety. Always bed in lowest position. Side rails up times 2, and only 2, right? Unless 3, but we'll learn all that later. 2, and call bell is within reach. We're going to check all of her tubes, her drains, her IVs, all of that to make sure nothing is tangled up, because guess what? We had her sitting up, we had her rolling over, we had all this, that, so she could be tangled. We don't want nothing tangled. Nothing in the way is a trip hazard. And then we're going to make sure that we address the 4 P's, which are potty. So, Miss McDonald, do you have to go potty?
No, I'm good.
Okay, and next one is pain. Are you currently in any pain?
My abdomen still hurts.
Okay, I'm going to check on your time to get you, see when it's time to get you your next pain medicine. Are you in a comfortable position?
Yes.
Okay, and do you have everything you need around your bed?
Yes.
Okay, so I'd make sure that if she said she wanted her purse or personal item close to her, she had it within her reach. Then again, you're going to be assessed on your attire, that you're in full attire. I did notice some people still have in nose rings, earrings, and stuff like that today. So make sure you get them out. Your daily clinical evaluation will reflect that today.
Can I ask a question?
Yes.
This came up earlier. You know, the big thing about covering tattoos, but for checkoffs to make it easier for them to do, can they not have, can they, if they have...
They can take the sleeve off when it's time to do the check off, yes.
Like a lot of people wear shirts like this, so can they, because they're
Oh,
trying to
gotcha.
cover up their tattoos,
Yeah.
can they show their tattoos?
Yes, for that purpose, yes.
Okay, good to know.
And then your demeanor, how you speak to the patient, how you treat them. Like, can I see your wristband? You just yank on them, like we're not going to do that. Can you roll over in the bed and push them? Like, we want you to be thoughtful of your patient, all of that good kind of stuff. And then your bedside manner, again, how you are smooth, are you nervous, all of that kind of stuff. And then a time deduction. You have 20 minutes to do all this. Head to toe, 20 minutes. Okay? You practice, and it does. Just like vital signs, you guys were doing great today. The more you practice in order, practice right every time. The same way every time.
Okay,
It's not an
listen.
issue.
And also, I'm going to go ahead and say, I don't know if y'all noticed on your calendar, we are doing a video physical assessment, meaning you and your partner record your assessment. Now, one of our big reasons why we switched to this is because it's not so that we don't spend, because physical assessment checkoffs take a long time. But we realized, okay, you record your checkoff. This is why you do not wait. It's due on that Monday at whatever. Don't wait until that night to do your physical assessment. Oh, it's only going to take me 20 minutes. No. Because think about it. You do your physical assessment. You record yourself. You go watch it with your rubric now in your hand. And you see if you did everything you were supposed to do. And you're like, oh my God, I forgot the whole neuromuscular section. Well, guess what? You don't just get to add in your neuromuscular section. No, you go redo the whole video again. No editing. There is no editing, no adding in stuff, no, we can tell, I promise you. If you pause it and then try to go do something and then come back, it's obvious because you're not right where you left off when that video starts replaying. Okay? Now, what do you think our purpose is for that? Practice, practice, practice. If you mess something up and that,
September 8th is when it's due.
yes. If you mess something up and you got to go redo it, guess what? You just did a whole new physical assessment. Yay. Practice, practice, practice. That's why we don't want you to wait until the last minute.
Is it in the lab?
Next week.
Does it matter?
Well, they have to have a partner.
Yeah, I know. So you want me to just give them
That's
some
okay.
guidelines we did?
Yeah.
Okay. So you can do your video at home.
Thank God.
Is it better to do it in the lab? Yes. But can you do it at home? Yes. You obviously need a partner. So you need to get your mom, your dad, your brother, your sister, not a toddler, okay? An actual adult, please.
That'll be to your advantage, believe me.
Now, in the video, do you have to be in clinical attire? Yes. Does your partner need to look presentable? I don't want somebody laying on the couch or the bed or something in their bra and boxers and panties. No. I don't want all that. They need to be clothed and covered, okay? I'm not saying they gotta go wear a suit and tie, but they need to be covered. Yes, regularly dressed.
And like, how would you want us like to set it up? Like, do y'all have to see? I know y'all will.
You have to, your video, so when you go and set up your stuff, okay? And y'all make it presentable. If you're worried about your house, my house looks a hot mess because I'm a single mom in it with 3 kids right now. Don't have time to clean. But y'all be mindful, everything still has to be professional. If you're worried about that, then go do your recording with your classmate partner in the lab.
Because you will have to take it in landscape view. You are going to have to scan your entire room so that we know that there's no cheat sheets up on the wall to tell you what to do next or what not to forget. So we're going to see the entire room you're in.
Yes.
Okay? And I will say, as Miss Tabor, just because she's really, she's seen it all, almost. She's seen way more than all. But if you're doing it at home, I'm going to be watching you a little bit harder than somebody that's in the lab.
You might want to put your dogs up for a while, because they always want
Yeah.
to be right in the middle. Cats, they want to be
Your
right in
dogs,
the
your
middle of what
kids,
you're
it
doing.
needs to be just you and your partner doing the assessment, okay? We don't want all the background noise because we have to hear what you're saying.
You will have to talk loud enough that this will pick up everything you are saying and doing. Because again, if you do not say it, then we assume you are not doing it. And you have to say the prompts on there and do everything. Okay. How did I teach last week? The same way. You push the bottom of the toe, you make it blanch, and then you let it go.
Make sure your partner knows if you do it at home, they still like to please just take it serious and be professional, okay?
And they do have to be in pain. They have to.
Yeah, they do
Yes,
have to be
and
in pain.
your partner does have to state a pain. We don't care what kind of pain, because now you have to go through your old carts. If they say no pain, then you have no old carts to go through. So your partner does have to have pain. Okay, that's the only abnormal that we require. Okay. Also on the video, like she said, after you show us the view of the room, you need to make sure you have it set up to where everything you do, we can see and hear. Okay? If I can't see and hear it, you get an email back from me and saying you gotta redo it.
Oh, would it be okay too, if we have a third party recording?
That's fine. Yes.
You said show the room, I think I missed that.
Yeah. Landscape, and you're gonna have to show the room beforehand so that there's no, full circle all the way around so that there's no cheat sheets hanging up or anything like that. And the other thing is if we do not feel comfortable with your video, or we feel like there's cheating or there's whispering between partners, because now if you enter a third person who's got the camera, now there can be somebody back there going, you know, stuff like that. Okay, that's still considered cheating.
And if we send it back to you to redo it, then what's the highest grade you can make?
If I feel like you're cheating, guess what? You're going to come in and do it live in front
That
of
right
us.
there.
Dude, does the time start as soon as we start talking? Like it doesn't
Yes.
include the roof scan?
Yeah. When you say I'm going to begin my assessment is when we'll start timing.
Is it okay if we use like little body mics and our tripod
Yeah.
and stuff?
If you've got that equipment, that's fine. And if you just don't want to go through all the trouble of doing that and you're afraid, Miss Tabor's going to be like, uh-oh, just come in and do it in person. I'll come and meet anybody in person and do it in person. Okay? Because for me to do all of that is way more trouble than me coming in to do it in person. I'm sorry if I was a student.
So the physical assessment one's only video, it's not in lab.
It's the
With
only
you
one.
guys.
Yeah.
So,
Now, we highly encourage, if the only reason previously Ms. Horton and I decided that y'all can do at home is because there are so many of y'all.
Right. And even at 20 minutes apiece.
At 20 minutes apiece, so
Times.
maybe might not be a lot of like lab capability for everybody. We do understand, you know, having to come and record outside of lab hours, that some of you do work and have children and, you know, stuff like that. So we are being mindful of that, but y'all still have to turn around and be mindful of what we're asking you, okay?
so you're saying that you will come over there while we're doing our video, like to watch it?
Not your video.
No. If you're doing a video, that's fine. What I'm saying is, if you don't want to mess with doing a video because you're afraid that Miss Tabor might think I'm cheating, or I'm not gonna, you know, I just don't have the equipment, my house isn't clean enough, I've got too many kids, too many dogs, and you feel like it's too much trouble to video record, just say, hey, Miss Tabor, Miss McDonald, I just want to do mine in person.
Oh, so it's like not mandatory to do it.
No.
But it still has to be done before the due date.
Yes, which is September 8th.
And so we don't have to do the ratings on some of on all of
Yes.
Like the rate, yeah.
So we
I think
don't
it's
have to
the rate on the pulses. We don't want the rate on the pulses, just the quality and like.
And I will only I'll say for the rest of everyone, we will only accept 2 methods of your recording because it's what we found works. You either have to convert your recording to YouTube and send us your YouTube link, okay? Or you have to record it on your WebEx and then send us your recording link, okay? We've had students try to do other different ways. It just gets really complicated, so those are the only 2 ways we're gonna do. So if you don't know how to upload to YouTube, find a friend who does, ask them to show you. This is another reason why we're not waiting until Monday night at 6 o'clock to do our video, okay?
I'm just gonna go over a couple of quick things that are not a part of this, that will be test worthy, okay, on the written test, that I wanna make sure you get the opportunity to see. Okay, so some of the things, does anybody remember tactile fremitus from the lecture? What is tactile fremitus? Okay, so come here. Tactile fremitus is, she's gonna turn around,
Say 99.
and she's gonna say 99.
99,
Okay.
99, 99.
Okay, what am I feeling for?
Vibration.
Vibration. What does a vibration mean? There's congestion in there, right? Because it's vibrating when she talks. Okay, who remembers what the thoracic expansion is? Correct. So come here, Miss McDonald. And I'm going to bend down for that round. So if we have any question as to whether or not her chest is rising and falling equally, we can come down here and make a W with our hands, and when she breathes, we can see that we make sure and we follow our hands to see that that is occurring. That is called thoracic expansion. Okay, auscultation, I'm just going through the cheating, or our teaching sheets, precordium. Okay, remember this is called the precordium. What's a neck vein distension? JVD. Jugular vein distension. How do we test for that? We have patients in the bed, we lay them back at 30 to 45 degree angle, and if they have jugular vein distension, that jugular vein will pop out. What is that a sign of? Something going on with the heart. Typically, with heart failure, there'll be fluid volume overload, so it's the extra fluid there. Okay. We did that. We talked about the bruits, the murmurs. We talked about that. Inspect. All of that. Okay, what's borborygmi? Borborygmi. She has it on here. She must have talked about it. B-O-R. B-O-R. Yes, I said it twice because it's in there twice. B-O-R. B-O-R-Y-G-M-I. Nope. So when you're listening to bowel sounds, how many bowel sounds should you hear on a normal person? Huh? There's 4 quadrants, but if we were to count, okay, 5 to 35 is normal. Well, when you put the stethoscope down and somebody's having GI troubles and all you hear is tinkle, 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 and it just nonstop instead of gurgle, 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 gurgle every once in a while, that's borborygmi. It's what you would hear when somebody's maybe experiencing diarrhea. When you hear it out loud, have you ever heard somebody's like, and you just hear it kind of rumble? That's borborygmi. Let's see.
So would you explain that as like abnormal abdominal sounds, or?
You would just say borborygmi or hyperactive bowel sounds. That's just a technical word. Okay, that's all I have on my teaching sheet. Do we want to take a break?
Yes.
Give them a time.
Okay, it is 9:59. Y'all just be back at 10:10. We'll take a little 10-minute break. We got lots to do.